Okay. So, hi, I'm James. I'm a nurse practitioner. I'm going to be doing your head to toe assessment today. How are you?
Good.
Wonderful. Are you in any pain?
No.
Okay. And is it okay if I complete this assessment on you today?
Yes.
Okay. Wonderful. So, right away, I've washed my hands. I've established consent. I am noting her general mood, affect, hygiene, behavior. She's dressed normally. She came to the appointment on time. She's oriented to time, place, and her name, but I'll ask her those questions anyway. Can you state your name and date of birth?
Krista Witten, March 20th, 1994.
Okay. And then do you know where you're at right now?
Research Medical Center.
Okay. Do you know the date?
November 28th.
Are you sure on that?
I don't know.
It's okay. It's okay. Okay, so she's alert and oriented to time, place, name, situation, everything that's going on. So we will just begin with her hair, and I'll just note the general texture, consistency. Part her hair, look for lesions, asymmetry, swelling, cyanosis, note the quantity, and looks okay. And just her head, just normal cephalic, there's no asymmetry, swelling, anything that I can see, just from how she generally presents. And from this point, I can start with the cranial nerve assessment. And the first nerve is the olfactory nerve. This is often omitted from the assessment, but I could test that with having her close her eyes and then smell something strong like coffee or cinnamon and have her identify the smell. And the second nerve will be the optic nerve. With this, we could have a Snellen eye chart, which I don't, for today's purposes, I don't have, but I have to hold the card about 2 feet away and have her identify the lowest portion of the card that she could. And I will also perform Perla on her, so people's equal reaction, reactive to light and accommodation. So I'll just have her look forward, and she constricts. Pupillary reaction on each side, and I can note the corneal light reflex, and it is symmetric, which is good. And while we're here, I can palpate the conjunctiva and the puncta, and I don't know any icteric sclera and any erythema or redness. There's no exudate, no swelling, so no abnormalities there. And for her eyebrows, I can just note the palpebral fissure of it, and there's no lesions, and they're symmetric, and they look wonderful. So I can begin the fundoscopy at this point with the ophthalmoscope, and I would dim the light, and I would have the patient stare forward at me and examine her left eye with my left eye. But at first I would note the red reflex, and she has the red reflex. If she didn't have that, it could indicate malignancy, opacity, cataracts, an obstruction there, that red reflex should be there if it's not present. That is abnormal. And I'll have the patient look forward, and I'll go in about a 20-degree angle, and from the red reflex, I will move in and then increase my acuity. Oh no. But actually, oh no. Okay. Sorry about that. So as I moved in, I was noting the shape and size of the optic disc, which was a yellowish, orange color. I noted the ratio of retinal vessels to arteries, and then the last thing I'll have the patient do is look directly into the ophthalmoscope, so look directly at me, and this helps visualize the macula. And yeah, you want to do that last because it's the most uncomfortable portion of that fundoscopy. And that concludes the fundoscopy. And the next thing we could do is the static wiggle test. And this is where I'll have the patient put your hand over your right eye. So we'll be covering the same eye. And then tell me when you see the wiggle of my fingers coming to.
I can see the wiggle of your fingers.
Okay.
I can see the wiggle.
Yeah, okay. Alright, other eye?
I can see the wiggle of your fingers. I can see the wiggle of your fingers.
And this just helps test their peripheral field vision and if there's any abnormal response in the field of their vision in all quadrants. You for turn. Okay, and with that, we can move on to the third, fourth, and sixth cranial nerve, which is the ocular motor, the trochlear, and the abducens. And so this would test the extraocular movement of her eyes, and I would just have her look straight ahead at this finger and then follow my finger. So we'll just do a wide H, so follow my finger. Keep looking at the finger. Okay, keep looking. Very good, very good. So that tested the extraocular movement of her eyes and within those cranial nerves I had just listed. And at the end of that assessment, I went in and that tested the accommodation and convergence of her eyes, and they did constrict, and they did have increased convexity. So all normal responses there. And the fifth nerve, the trigeminal, with this we could do the corneal reflex, but for today's purposes I'm not going to actually do it. I would just brush her eye with the end of a cotton ball. And then we could palpate her temporal mandibular joint. So open your mouth, yeah, and close. Okay, and there's no crepitus or swelling or redness. Everything feels good. And to test the sensory function of trigeminal nerve, you could just brush certain parts of the face and then have her touch where I just brushed. So close your eyes. So touch where I felt, where I touched it. Okay. Okay, good sensory reflex there. You can open your eyes. So that tested the ophthalmic, the maxillary and mandibular portions of that nerve where they innervate, and she had good responses there. And I'll have her use her mouth to press against me. So press against me only using your mouth. Use your mouth like that against me. There you go. And then go against me. Okay, so that is testing her trigeminal nerve, the motor portion. Okay, and then the seventh nerve will be the facial nerve, and I'll just have her smile, show me all her teeth, all your teeth, and then smile just like this. And then frown, and then puff out your cheeks. Yeah, good. Okay, great. And try to open your eyes against resistance. Try to open your eyes. Okay, good. And then 8, the vestibulocochlear nerve, that will test her hearing acuity. So with the beginning of that, I will do the whisper test. So I'll occlude the vagus of her other ear, and then go on the other side of her and whisper a word and just have her say the word. So yeah, so she said the word that you can say it out loud.
Hospital.
Okay.
Apple.
Yeah, okay, so she performed well there. And for her ears, I'm just noting the position, the auricle, any exudate, any swelling. They present well, and we could perform the portion of the assessment with the otoscope. And for this, I will pull the pinna up and back, and tell me if you're uncomfortable at any point. Okay. So I can visualize the handle of malleus, the cone of light, the incus. There's no exudate. There's no swelling. And then with the eyes, also I would have been noting for papilledema. Yeah. And do the other eye, or other ear, I mean. And pull the pinna up and back. Okay.
Yes.
Okay, so again, visualize all the structures on the other side that I just listed. And no abnormalities, no exudate, swelling, redness, anything like that. And again, with the ears, we could perform the Weber test, which will test for lateralization. I will ask her to tell me if she feels the vibration on equal sides of her head. So, yeah. You feel it on both sides? The vibration?
I feel.
On both sides?
Yes.
Okay, so that's testing for lateralization. of her hearing acuity. She felt more on one side to be a positive Weber test. Now we'll do the Renee test, which is testing bone and air conduction. And we will tap that and put it on the mastoid bone. And then tell me when you stop feeling it.
I stopped feeling it.
You hear it?
Yes.
Okay, so that's a negative Renee test. That's because bone conduction continues after, air conduction continues after bone conduction. So that was good. Good, good, good. Okay, and then the 9th and 10th nerve, the glossopharyngeal and the vagus nerve. This is where I will have the patient open her mouth, and I will visualize the uvula. So let's use this tongue depressor. So open your mouth and say ah. Say ah. Okay, so I was looking at the uvula, looking for swelling, asymmetry, looking at her buccal membranes. Everything was pink, moist, intact. Her hard and soft palate. Good. And then the 11th nerve, that will be the spinal accessory. So I'll just have the patient do a shoulder shrug, so up. Okay, and then use your neck to turn against me. Okay. Yep, like turn against it using your neck. There you go. Good, good, good. Okay. Okay. So that was the spinal accessory nerve. The 12th nerve is the hypoglossal nerve. I'll just be listening to the patient's voice, monitoring for hoarseness, raspiness, and then have the patient stick her tongue out, and then move it side to side, and then up. Okay? And I was just looking for fasciculations, any lesions. Oh, God. Damn it. Yeah. Any lesions. Yeah, and then also when I was doing the lateral rectus eye movement, I was also monitoring for nystagmus as well. Okay, so with the nose, I'll get my otoscope back out and just be looking at the bridge of her nose and looking up for obstruction, any deviation of the septum, noting the turbinates, the quantity and distribution and texture of the hair. Nothing, no abnormalities there. With the patient's throat, I will palpate for the thyroid cartilage and the cricoid cartilage and the thyroid gland, and then I'll have the patient swallow, and there's no deviation, no swelling, no nodules. Yeah. And at this point we could start the lymph node exam, and we will we'll start with the preauricular, the postauricular, the occipital, the tonsillar, the submandibular, the submental, supraclavicular, the deep cervical, the supracervical and posterior cervical. And while I'm here, we can feel the frontal sinuses and the maxillary sinuses and see if she has any pain when I palpate or touch them. Did you have any pain when I did
No.
that? Okay. Okay, and at this point we can move on to the lung and thorax exam. So we can begin with auscultation. And this will just be auscultating all lung fields. I'll have the patient breathe out, in and out through her mouth. So, you know. And I'll do the posterior side. While I'm on the posterior side, I can test for normal respiratory expansion. So I will have the patient take a big deep breath in and out. Okay, and there was symmetric movement of my hands. While I'm back there, we can also test for diaphragmatic excursion. So this would involve I would mark going from the inferior angle of the scapula. I would have the patient take a big deep breath out and hold it. So breathe out and hold it. Okay, and then take a big deep breath in and hold it. Okay, and that's normal diaphragmatic excursion, about 2 to 3 centimeters. If it was over that, it could mean a C3, C4 nerve root lesion or diaphragmatic nerve issue. While I'm back there, I could also do costovertebral angle or tenderness. So I would hit with the palmar side on the costovertebral angle and see if she had any tenderness there. And I could test for percussion, so do all lung fields as well. Okay, normal. And that would just be testing for dullness or consolidation. would just be noting the depth of her inspiration and expiration, the rate, the ease of expiration and inspiration in her breathing, the overall contour and shape of her thorax is symmetrical, atraumatic. Tactile fremitus, so I'll have the patient be upright and repeat the words 99 to me.
99. 99. 99.
And then every time I touch your back here.
99. 99. 99.
Okay. Before we would have looked at any lesions of her skin and noticed any abnormalities with her nails and on her toenails. It looks like on her face she has some benign melanocytic nevi, which are 0.1 by 0.1 millimeters. Okay, and with that we can begin the heart, and I'll have the patient lay back, supine, and we will auscultate for 1 minute using the diaphragm. We would palpate for the second intercostal space to the right of the sternal border, and that would be the pulmonic valve, and 2 intercostal spaces down to the left, that would be the aortic valve, and then going 4 intercostal spaces down to the left of the sternal border, that would be the tricuspid valve, and at the midclavicular line, 5th intercostal space down, would be the point of maximal impulse and also the mitral valve. And we could also palpate here and try to feel for any pulsations or thrills or heaves. So I will, I'm auscultating for 1 minute at each of those landmarks. And also with the bell, I will auscultate at each of those landmarks, and then I'll have the patient lay in her left lateral or recumbrant side, so just kind of lay on your left side, and then I would auscultate the mitral valve and the tricuspid valve. That's with the bell, and I'll have the patient sit up and then lean forward, and then I'll auscultate with the diaphragm, the aortic valve, and the pulmonic valve. And she had a regular rate and rhythm. And then also I was monitoring for any pain or palpitations when I was palpating her. And with that, we could start the peripheral vascular assessment. So I'll have the patient put her nails together like that. Okay. No clubbing. And then, okay. And then I will feel her nails for capillary refill. Pinch her skin for turgor on the upper extremities and the trunk. And monitor for edema, no edema. And for hair distribution, if there are abnormal patches of hair missing, it could indicate arterial insufficiency. So she is normal across the board there. And we could do the pulses next. So the carotid, the brachial, the radius, popliteal. This is often sometimes very hard to palpate, but I'll have the patient lay back, and then lift her head up, and then lift her knees up and try to do deep palpation. Okay. And do that on the other side, and then her femoral pulses as well. Okay. And the posterior tibial. And dorsalis pedis. Okay. And the abdominal portion of the exam, we could begin next. I'll have you lay flat, and we could begin with auscultation in all fields. The right upper quadrant, left upper quadrant, the lower left quadrant, lower right quadrant, and she had and I'll do light palpation. Any pain? Okay. And then deep palpation. Okay, and we could percuss for the liver dullness. So I'll have patient lay her hands at her sides and start kind of at the nipple line, and then palpate or percuss down. Okay, and then starting at the costal margin where there's tympany heard, I would go or percuss up. Okay, and normal diameter would be 6 to 12 centimeters. And if bigger than that, maybe it could indicate hepatomegaly. And I could palpate for the liver, and I'll have the patient lay her hand at her side, lift up on the costovertebral margin below the 11th and 12th rib, and have the patient breathe in and out. Might as well do this too. And have the patient breathe in and out, and out. was able to palpate the tail of the liver and to detect splenomegaly or try to palpate the liver, I'd lift on her left side and have the patient breathe in and out, and then in the costal margin try to palpate for the spleen, so breathe in and out and out. And I was not able to palpate it. If there was splenomegaly, it would often present by expanding anteriorly and laterally. So if you can palpate it, that would indicate splenomegaly. And for the kidneys, the right kidney, I would just lift up on the posterior side and the costovertebral angle and try to do a hooking motion in the costal margin and try to palpate that right kidney. For the left kidney, same general manner, lifting up below the 11th and 12th rib and the costovertebral angle. Breathe in and out. And out. Yep, trying to palpate the left kidney there. And percussion. So tympany is heard in the gastric bubble in the right lower quadrant. More dullness in the liver area. And I'll have the patient come up, and she, before I started that, I was just noting the contour and shape of her abdomen, noting for any umbilical hernia, any striae or vascularity, noticing any accessory breathing muscle use. And any masses or lesions or redness, erythema. Okay, we can begin the motor and cerebellar function test. And first I'll have the patient walk from this end of the room to that end and just monitor her gait. So go ahead and walk. And back. Okay. And then I'll have you do what's called a tandem walk, where you put each foot in front of the other foot and walk in a straight line. Wonderful, okay. And then I will have you come back here. I'll have her do the Romberg test, and this is where I would have her close her eyes for 30 to 60 seconds and look at her, any swaying, and monitor for any dizziness. She should be able to stand there still for 30 to 60 seconds without any abnormal swaying. Next we'll do the pronator drift. I'll have her extend her arms out, palm side up, okay. And then I will briskly tap down her arms, and she should be able to hold it there. So she held it there, palm side up, after I briskly tapped it down. So no abnormality there. I'll have her sit back on the table, and then we can do rapid alternating movement. So I'll have her with her palms perform this motion. So do that quickly. Okay, that's good. And also touch my finger and then your nose rapidly. So like that. Yeah. Okay. 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 And then pain, vibration, sensory. So I'll have the patient close her eyes, and you tell me if it's vibrating.
Vibrating.
Okay.
Vibrating. Vibrating. Vibrating.
Okay. And then for temperature, I would feel the other sides of the dorsum of my hand with her upper extremities. Normal temperature. Is this close your eyes? Is this cold or hot to you?
Cold. 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 Cold.
Okay. Okay. And then with and then I'll ask her to identify a sharp sensation or a dull sensation. So close your eyes.
Dull. 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 Sharp.
Okay, close your eyes again.
Sharp. 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 Sharp.
Okay, so no abnormal response there. Graphithesia, I will ask her to identify the number that I draw in her palm. So close your eyes.
Seven?
Yeah, good. Good. So that was good. And then I'll ask her to close her eyes, and I'll perform sturginosis. So I'll have her try to identify the object that I placed inside her hand. So
Cotton ball.
yes,
Safety pin.
yes, good. Yeah. Okay, you can open your eyes. Okay. At this point, we could begin the muscle strength and function test. So I would palpate her neck, her shoulders, her elbows, her wrists, her hips, her knees, her ankles, all monitoring for crepitus, deformity, redness, tenderness, swelling, erythema. Nothing abnormal there. I'll have the patient hold her arms out like that, try to fight against me. Or so go outward, inward, and put your palm side in, go inward, go press against, okay, good. And go with your legs, push up, test quadricep strength. This is all grade 5. Lift up with your feet, press down with your feet, okay. Go back with your legs, okay, so hamstring strength. Lay back, and I'll lift the patient's neck up, and there should be no pain or restrictions felt. If she felt the need or reflex to lift up her knees, that would indicate a positive Babinski test. I could perform the straight leg test, which would test for lumbosacral radiculopathy or sciatic nerve issues. So no pain there. And while I'm here, she can go press inward with your, okay, press outward with your legs, okay. Come up. And with your, press your hands out, okay, and then try to keep your fingers still, and I'll adduct the fingers, and that's good. Put your thumbs inward, and okay, normal strength, grade 5 there, and then grab my fingers and pull. Okay, yeah, so normal grip strength there. Yeah, and then the last thing we could do for the head to toe assessment is her reflexes. So, so with the brachial, I would have the patient slightly relax, okay, and I slightly pronate her hand, and then monitor for radial reflex here, or brachial. Okay, slight reflex felt there. Okay, and with the brachial radial reflex, I'll have the patient slightly pronate their hand, strike the radial. Another here. Okay, and then I will do the tricep reflex and relax. Shrug. Relax. Shrug. Relax. And tricep on the left side. Okay, and the patellar reflex. So I would palpate for the patellar tendon. Palpate for the patellar tendon. Okay, that's the knee reflex. The Achilles reflex, I'd have the patient slightly dorsiflex and strike the Achilles tendon. Okay. Try to relax. Okay, and test for ankle clawness. I would have the patient rest their foot on my knee and oscillate up and back. And then at the 4th or 5th oscillation, I would just monitor for clawness or continued oscillations. And do the same thing on the other side. Okay, and no continued oscillation or clawness. Yeah, and I think that concludes my head to toe assessment. So thank you so much for participating. You're a wonderful, wonderful patient. Thank you for establishing consent in the beginning as I wash my hands. So, okay.